My name is Karen Stahlberg, and I'm representing the medical school and the Department of Learning Health Sciences. And we're here today to listen to our amazing guest speaker, who I will let Dean Williscroft introduce you to. But part of the importance of this gathering is that we've got individuals who are all focused on educating healthcare providers who teach other people how to become healthcare professionals. And so that's a unique group. And to honor that, our colleague and graduate from the University of Michigan, Dr. David Howell, has sponsored today's lecture in honor of Dr. Ben Gilmore. So I wanted to let Dr. Howell come up for just a second or three and introduce Dr. Gilmore. So let me introduce Dr. David Howell.
Thank you, everyone. How many medical students here? Raise your hands. Okay, couple. I was a medical school student here once, and an undergrad, so I tell people I was on the 8-year plan, but I did get 2 degrees along the way. I created this lecture several years ago to honor Dr. Gilmore, who was one of my professors when I was a medical student. I did all my third-year rotations at Henry Ford Hospital, and Dr. Gilmore was on the Department of Otorhinolaryngology here, but practiced there. He was an awesome teacher. He really practiced the art of medicine well and made a huge lasting impression on me. And I wanted to honor him, as we should all consider honoring those teachers who taught us, particularly those great educators in medical excellence. And so, Dr. Gilmore, again, thank you very much for being such a great teacher. I'm glad you're here, and I'm proud to have an opportunity to sponsor this lecture. Thank you, everybody.
And now it's actually my distinct honor to introduce Dr. Jim Williscroft, who's the dean of the medical school. Also one of my amazing teachers. He hates this when I tell the story, but when I was a medical student, Dr. Williscroft was the faculty on service, and I learned a lot of things, including how to tie fish hooks. Flies, they're called flies, flunk. Total flunk. I'm a gynecologist, you know. He wasn't good enough for medicine. Let me introduce Dr. Williscroft, who will introduce our speaker.
Thank you, Karen. It is a great pleasure to see all of you here today. Larry Gruppen and I were just reminiscing for a few seconds the genesis, if you will, of this medical education day over 15 years ago. Neither one of us could remember exactly when, but to see how it's grown, to see all of the young people, to see all the faculty, students really passionate about education is a tremendous pleasure. And I want to thank you, Dr. Howell and Dr. Gilmore, for how you are enabling this, and we see the tradition continue. It's really my great pleasure at this time to introduce Dr. Catherine DeAngelis. You see up there her official titles, but I think actually the journey, the person, is much more important than the honorary degrees and all of those other things. So let me tell you a little bit about Dr. DeAngelis. Probably many of you know Kathy best, as her editorship of JAMA was so seminal. From 2000 to 2011, she was not only the first woman who was editor-in-chief of JAMA, but the first pediatrician. Those were very important times. She championed transparency, dealt with conflict of interest, professionalism, dedicated a whole issue of JAMA to medical education. But there was a story before that. Let me just share that with you a little bit. She was a granddaughter of Italian immigrants, grew up in a small Pennsylvania town, went to nursing school, practiced as a nurse, decided to go to medical school, graduated from the University of Pittsburgh Medical School, did a residency in pediatrics at Johns Hopkins, went off, and actually worked in a community clinic. In the clinic, she recognized that there were big gaps in care. Gaps in primary care due to access, financial issues, and way before it was popular, in 1973, published a book looking at nurse practitioners and resident teams, basic pediatrics for primary care providers. Once again, 1973, teams, if you will, way before we thought of interprofessional education or any of the common buzzwords now. So Kathy was way ahead of her time in many ways. Went back to Hopkins, full professor there, only the 12th full professor in Hopkins history. I would dare say, at least at that time, they weren't the most progressive institution. And so she was very distinguished in her career at Hopkins. Served as vice dean for academic affairs and faculty. As such, really championed women's presence on the faculty, and very importantly, led a major curriculum reformation in Hopkins as the vice dean. Went on to JAMA. The rest of the history is well known to you. Dr. DeAngelis has helped shape the conversation of academic medicine, of education, for many decades. And it's my great pleasure to introduce a colleague and friend, Dr. Catherine DeAngelis.
I'm not going to tell you how much I paid him to say that. Good morning, everybody. And I want to thank you all for inviting me to this very exciting meeting. I mean, this is really terrific stuff. I just want to point out, it says university, I think that should say extinguished service professor. That's probably what it is. But because I think everyone who gives a talk, no matter what it's about, you should disclose your, what the devil? Oh, okay, there it is. My financial disclosure, that's in every language I've ever given this sort of talk. That one next to the bottom is Burmese, but you don't have Burmese in your computer here. What's the matter with you? No Burmese. It's okay. And anybody here from New York? Okay, that's for you. Forget about it. All right. Now, what are the characteristics of, now I say medical profession. As Dr. Wolskopf said, I started out as a nurse. I have an MPH. I've been a patient. I have teeth. I've had PT take care of me. I wrote the first textbook for pediatric nurse practitioners. And like most women physicians, I did a lot of social work. So, you know, to me, the health team is what makes the whole field of health professions what it is. And it's so exciting to me to see this kind of display of the health professionals being together and working together. And I eager to be greatly congratulated for it. So while I say the characteristics of the medical profession, this is true to some degree for all 7 of the health professional schools here. And I'm sure my colleagues will discuss that from their perspective. But this is my characteristic of how I think any of the health professions are. We have a special knowledge and special skills. And because of that, that gives us an authority with rewards. Now, to any of you who think, especially being a physician, that you don't get a great deal of rewards, I want to tell you about the story of these 2 guys who were sitting on a train, in Italy. And the one guy looks at the other, he says, "Scusa, what's your name?" He says, "My name is Giuseppe Pascolini. What's your name?" "My name is Giuseppe Pascolini too. Where you from?" "I'm from Palermo. Where you from?" "I'm from Palermo. How you spell your name?" Guy takes out a pen and he makes an X. He says, "How you spell your name?" This guy takes out a gold pen, nice piece of paper, makes 2 X's. So this guy says, "Hey, excuse." He says, "Are you Giuseppe Pascolini?" "I'm a Giuseppe Pascolini." "You're from Palermo?" "I'm from Palermo." "How come I get a 1 X, you get 2? He says, "Oh, I'm a Giuseppe Pascolini, M.D." I said, "I mean, it doesn't matter. He's an MD, so you get an extra X." No, that's the only time when having an extra X is more important than a single. Oh, no, that's a different talk. I'm sorry. Anyway, along with this authority and awards comes a great responsibility, and for us to have high standards. And along with that, you get to the self-regulation. That means we have a responsibility to regulate ourselves, unless we want some government agency or some outside force to regulate us. And I'll get into that a little bit more later. But this whole thing, the whole profession, and all the health professions are held together by this single important word, trust. We have to trust each other, and patients have to trust us. And we should never do anything to compromise that trust. That is the basis of professionalism. Now, what about this knowledge? Well, we have institutionalized knowledge based, this knowledge base possessed only by our members of our profession. We have data or information base that is rendered via universities and in clinic settings. We do apprenticeships, and we are all bound for and to continuous learning. Now, one of the problems in professions is ego, and I love this. This is one of my favorite Einstein formulas. Ego is 1 over knowledge. The more knowledge, the lesser the ego. Lesser the knowledge, the more the ego. So arrogance has no place. And I don't care where you see yourself on the health team, no arrogance. And what about authority? Others, patients, seek the help primarily or ultimately from members. And I put physicians there because I usually give this talk to physicians, but it can be to anyone. And one thing I think is important, that you say, well, who's the team leader? Well, it depends on the situation. In many cases, it's the physician. In other cases, it's the dentist. In other cases, it's the nurse. It could be the physical therapist, the social worker. It can be any of the health professionals. So I don't think this team captain makes much sense unless you know what the clinical situation is. And as I've already pointed out, prestige. We have financial and social rewards. And we have a power, socially and financially. How many professions do you have in which you tell somebody to take off their clothes and they do? Just think about that. I mean, that's awesome. I hope you dentists don't do that, but I mean, of course, you guys are talking about cavity excavation. This is a slide. I couldn't believe it. Cavity excavation. I come from northeastern Pennsylvania. The coal mining, excavation means, like dynamite sometimes. No wonder people don't want to go to the dentist. What's with you guys? Anyhow, responsibility, protection of patients. Always, always protect our patients. Self-care. We have to remain healthy, mentally and physically. And there are too many times when we have access to drugs and other meds that are not very healthy. And so we have to be very, very careful about being exposed to all these potential things that could harm us. And we have to protect each other. We have ethical and cordial behavior with patients and colleagues, always. And, you know, even beyond those of us who are health professionals, there are members of the health team. The most important member, incidentally, is the patient. But there are others. How many of you have taken the time to thank the maintenance people or the dietary people? Can you imagine what our lives would be like without them? They're members of the team too. And you would be amazed at their reaction at a simple, Mr. So-and-so or Miss So-and-so, thank you very much for being part of the team. It takes nothing on our part, but it's very important. And we should use our authoritative power to oversee our own members. How many of you in this audience have observed a member of the health professions behaving in an unprofessional way? Okay. How many of you have reported it? Oh, you know, this is more than I've seen in most audiences. Usually if I get one or two. How many of you have at least gone to the person and discussed it with them? You guys are wonderful, because that is unusual. And yet, we think by looking the other way that it's all going to go away. It's not our responsibility. Well, it is. And if we don't do it, I'm telling you, others are going to do it. And unfortunately, it's already beginning to happen, and I'll get into that in just a minute. This is the self-regulation or autonomy. Autonomy is a word that can be misinterpreted. It doesn't mean that it's only us and we don't pay attention to outside people who have a say in overseeing what we do. But the regulation should come only from those who have the same knowledge base and experience. That's the regulation. The regulation of licensure is a legal right to practice. And the people who render that are mostly the people of our own professions. And of course, there could be outside individuals who are part of the committee. But the regulation itself comes from the members of our profession. The regulation of specialization are the rules set by professional boards. We have examinations for licensure and specialty practice in all the health professions. Now, what's happening, unfortunately, is we have a tremendous interference from business interests. I'm afraid that my profession of medicine it's gone from, and it is going from being a vocation to a business. And we see it so often, and it is very disturbing, because there's been so many conflicts of interest. Working for the marketing branch of a for-profit companies, or you pay for your name being on a research paper or speakers bureaus, etc., using slides provided by the pharmaceutical companies. The business set the rules. They say, spend less time with patients. You only have 6 minutes. And they wonder why it's so hard to really establish a relationship, a true relationship with patients. Order excessive tests. Isn't that just amazing to me? That we have these wonderful clinical skills, and instead of using them, we just order a bunch of tests, thinking that, oh, those are objective, never realizing that those so-called objective tests have errors too. I mean, we talk about p-values of 0.05. That means we will accept an error 1 out of 20 times. So if you order a chemistry panel and a CBC and diff, one of those values, by chance alone, is going to be wrong. How objective is that? And so you have to use the skills that we've been taught and that we teach. And you can't just depend on some machine to do it. Now, why do we do those? Why do we use those machines? Well, sometimes only a machine could do that. But sometimes, for the more simple things, we should do things that involve interacting with the patient. Touching a patient is extremely important. And we have so many machines now that come between the health professional and the patient that we forget about touching. And I find that very disturbing, especially the so-called health record, you know, where you're so busy that you don't have time to look at the patient. That's not right. And when you look at, yes, they're very wonderful, and they're tools, and should be used as tools, not an instead of. Ordering these excessive tests is it's money. It's the business of medicine. Performing unnecessary procedures, the business aspect. We order expensive drugs when others would do. Why? Because the pharmaceutical representative tells you, oh, this is great stuff. Yeah, they don't tell you about the bad side of it, and they don't tell you how much it costs. Oh, well, my patient came in with a free certificate for the first doses. Oh, yeah, but then after that, you're writing for the more expensive drug when a lesser one would do. That's wrong, and that's unprofessional. And then the business sets offensive language. Now, I've heard a number of you, including Professor Stahlberg, refer to us as providers. Now, I can't understand why every Jewish mother in America hasn't risen up and just be irate. Can you imagine? I want you should meet my son, the provider. What? It doesn't work. We are not providers. We are professionals. And if I told you where that came from, it was from a bureaucrat in New York. And why provider? Because nobody gets upset when you try to regulate providers. Oh, you're going to try and regulate a doctor or a nurse or a dentist? Oh, no, that's no good. But a provider, sure, you can do it. It's a business thing. Please don't call ourselves providers. We're professionals. Okay? Sure. Right. And the business value of health care. Their stalwart is res tantum vale quantum vendi potest, which translated means a thing is worth what it can be sold for. We're worth what we can be sold for. What our knowledge can be sold for is a good business venture. And of course, the law of averages says if you put half of the world's economists on dry ice and the other half on hot stoves, they'll declare that on average they're comfortable, right? You know who said that? Melvin Chinovsky. You know who Melvin Chinovsky is? How many of you know who Melvin Chinovsky is? I bet you all know him. That's Alfred E. Newman's original name, incidentally. This is my favorite picture of him, though. I like this one. Anyhow, we are influenced, or at least physicians are, although nurse practitioners and other clinicians are beginning to get into the same game. This is the Bible for pharmaceutical representatives. It's influencing They say physician behavior. Be brief, be bright, and be gone. It's a 5-star Amazon.com, that's where I got this from, by Currier and Frost. Career Essentials for Pharmaceutical Representatives. And if I told you some of the stories that I've been told by former representatives, it would make your hair stand on end. So I won't do it. The outcomes of the profit strategy, unfortunately, which we have allowed in an unprofessional way, pharma's focused more on marketing and less on finding novel drugs. So the pipeline for new drugs is drying up. If you doubt that, these are the sales of name brand drugs at risk due to patent expiration. In 2011, they lost $12 billion in annual sales. 2012, $55 billion. 2013, $28 billion. 2014, $34 billion. 2015, $66 billion. And next year it'll be $30 billion. Around 2014, the pharmaceutical companies began to realize that they better be careful about where they're spending their money. You know, there are two divisions in pharmaceutical companies. One is the scientific division, in which some of the best and brightest physicians and healthcare scientists work, and they're wonderful. And then there's the marketing division, which the best and brightest salespeople in the world work. And it used to be that most of the resources and money went to the scientific division, discovering new drugs, and lesser to the marketing, selling the drugs. Now, I'm going to show you a slide in a little while, and I'm going to show you what happened. But in 2014, the pharmaceutical companies got smart and said, my God, we're going to lose all the patents on all our big sellers, so we better start discovering, put money into new drugs. Of course, you know what's been happening. When you can come up with a new drug, a vaccine for hepatitis A, it only costs $120,000. It's a cure, but it's $120,000. New cancer drug, where they charge $1,000 a pill. Why not? But that's another discussion. Now, the definition of a conflict of interest, which is exactly what I've been talking about. This is nothing new. Its main entry was in 1850, what was then just the Webster's Collegiate Dictionary. In 1850, it's a conflict between the private interest and the official responsibilities of a person in a position of trust. Remember that early slide I said? The thing that held our professions together was trust. Well, this is a conflict between our official responsibilities and our private interest, because we are certainly in a position of trust. And so, now this is something I had put together when I was editor-in-chief of JAMA. And I had someone look at all the articles in the Medline from 1970 through 2010. Actually, I have the data through 2014. And you can see there were essentially almost no articles published on conflict of interest in the medical literature until about 1988. And then you see that incredible rise, and it's now leveled off to about 600 a year. It's been at 600 since 2010. Now, what do you think happened in about 1988, 89? That's when the CEO of one of the big pharmaceutical companies decided to marry, that was the word used, the scientific with the marketing divisions. So suddenly, you had people who were putting more emphasis on the marketing. If I could sell a drug to people who don't really need it, they could use a less expensive drug. I don't need FDA approval. back then they said it cost about $800 million to discover a new drug. Now they say it's 2 or 3 billion. No one can ever provide. I keep asking them, can you show me where those costs come from? I know that a lot of it, maybe 2/3 of their costs, come from NIH-funded research, but they count that in, even though they didn't expend it. But it doesn't matter. It doesn't matter what it costs them, because the pharmaceutical company has a 23% profit margin every year. 23%. Even the banks don't come anywhere near that profit margin. And yet, they charge so much for drugs, okay? So, but back there in about 1988, they decided to marry the two. So, A, let's sell a drug already approved by the FDA to people who don't need it, okay? They could have use a cheaper drug. And two, if I can have this drug used by physicians for a drug for which it's not formally approved by the FDA, even better. A physician in the United States can write a prescription for any drug. It does not have to be FDA approved. As a pediatrician, almost all the drugs I used were not approved by the FDA because the pharmaceutical companies didn't include anyone under 14 in their clinical trials. So officially, it wasn't approved by FDA for anybody under 14. So what happened? You go to a meeting, and there's a doctor with a very good reputation in the field who is a member of the pharmaceutical company's speakers bureau, and he or she gets up and talks about a particular drug, and incidentally, well paid to give this talk, and all expenses paid, and they use slides prepared by the pharmaceutical company. And the pharmaceutical company says, oh, you have to use our slides because there's certain things that have to be in it. That is a lot of baloney. And so if you use those slides, they accentuate how wonderful the drug is. They don't say the bad aspects of it, and they don't tell you the price. So right away, good. Everybody thinks this is a great drug, and they don't care about the price. Most physicians have no clue what drugs cost. So they write it for that, augmented by the pharmaceutical reps, okay? Also, there's a plant in the audience at this conference, also paid by the pharmaceutical company, and they say, Doctor, we'd like you to go as just a general audience because we'd like you to take some notes on how well you liked what the physician who presented the slides, how well you liked it. Oh, and we want you to ask one question. And the question that the guy or woman in the audience says, Dr. X, have you ever thought of using this drug not only for Ratz-Frats disease, but what about Gesordenplatte disease? And the speaker saying, you know, as a matter of fact, I've used it for that. Off-label use. Now I'm using it for people for which it's not FDA approved. And if you think I'm making this up, I'm not. Believe me, I'm not. I've been there. Of course, I always appreciate the fact that I tease people that I have an Uncle Guido. I need him because of the pharmaceutical companies would like to shoot me because I talk like this. But I can prove everything I'm saying. Now, this is the other aspect. It says, what gets published? It says, I didn't exactly write the article, but, well, I didn't exactly do the research either. This happens, too. Been there, seen that. This is an issue of JAMA that we published just on the available information on guest authorship and ghostwriting with Vioxx. Rifecoxib is Vioxx. And we found over 100 authors who were paid by the pharmaceutical companies to write these articles, or actually the pharmaceutical companies had medical writers write the article for the doctor, who would put his or her name on there for a very nice honorarium, 100 of them. And of course, I got phone calls from some of them saying, I never did. And I said, well, I happen to have this letter here. Would you like me to fax it to you now? This is back in 1990s and stuff, okay? And I'd send it, and they'd say, oh, I'd forgotten about that. Oh, good. Over 100 physicians who were guest authoring never wrote the article, but put their name on it. Not good. This was the Vigor trial, the Vioxx, the original. And that was published in the New England Journal of Medicine, which is a fantastic journal. Okay? And Jeff Drazen, the editor, was, it happens to all of us. He didn't realize that they accidentally omitted about 4 myocardial infarctions and deaths in the study. And by the time they found it out, the drug had already been used by many, and still is, until people won't use it anymore. Now, the issue is that if they were honest in publishing it, there are a number of people who no other drug but Vioxx worked, and they would be willing to risk the actual risk of an increased myocardial infarction because they couldn't bear the pain. But instead of being honest, they used deceptive publications. And that is wrong. But it happens to all of us. This was our Celebrex. This is my own watch. Celebrex. If you look at the left-hand side of the slide, this was Celebrex, which is celecoxib, and then that's a non-steroidal and an ibuprofen. And you could see this was a study that was supposedly 12 months to show ulcer complications according to the traditional definition. And this study was sent we published it as a preliminary study because they only sent us 6 months data. So we published it as a preliminary study. I asked them 3 times, and I got it in writing, do you have the 12-month data? No, we don't. We have 6 months only. Okay, so I published it preliminary. And if you could see at 6 months, the celecoxib looks like it causes many, many fewer, certainly statistically significantly fewer ulcers than the other drugs. But if you take it out to the 1 year, there's no difference. Now, I'm using this slide from the British Medical Journal because it's a nice slide. But I became aware of this 2 months after we published it. And I made them write a correction and an apology to the readers for doing this. But they wanted to get away with it. And incidentally, it was extremely difficult to go into the FDA resources to find that they actually had 12 months data. That's why they thought they'd get away with it. But they didn't know there are ways to get into the FDA. Now it's easy to do it, but back then it wasn't. But when this happens to you as an editor, if you have a conscience, this is what it feels like. Believe me, that is what it feels like. Okay, so here's just another example. This is another article that we published with yet another drug. This is Avandia, where they try to bamboozle the audience, the makers of Avandia, and we published this paper and yet another editorial on ensuring integrity in industry-sponsored research. Now, the issue is 85% of the clinical trials in this country are paid for by the for-profit companies, which is right, and it should be. They're going to make the profit on it. They should pay for the expensive clinical trials. And that's not to say that all these studies paid for by the companies are wrong. That's not true at all. It's just the bad apples are really, really bad. And so I'm just showing you some of the things that happen in our profession that are very unprofessional, and we should never allow them to happen. And when we see it, we should report it. Then we have interference from legal interests. They tell you, practice defensive medicine, order unnecessary tests just to cover your whatever. Don't advise patients of human error. That's wrong. Your mother was right. If you make a mistake, you admit it. But they say, oh no, don't do that. And never apologize. That's ridiculous. Everybody has this fear of malpractice. Well, if you do something wrong, we are only human. I tell people, if you look at your white coat for physicians, it says MD, not MD-ity. So you make a mistake. You make a mistake, then there should be retribution to the people. And you know, that's what legitimate malpractice is for. But that's not the way it's practiced today, because there are many, many physicians who are involved and they have their cases settled out of court because it's less expensive than fighting it. I know 3 physicians who quit their practice in their 50s because that happened to them, and 1 physician who committed suicide because he was so distraught by, he did nothing wrong. But this is what happens. All right, who knows who this is? That's Sir Isaac Newton. That's William Blake's sculptor of Isaac Newton. And you can see Isaac Newton for many years was considered the epitome of integrity in science. And you can see intensely he's looking with his caliper and he's measuring something. And this is the cover of The Economist. Science and profit, are they partners or enemies? Look at that leering face. What's that in his right hand? Yeah, he's measuring too. And this is what's happening. The public looks at us now and don't have the respect they should have. And it's our fault. Now you can say, well, you know, we spend a lot of money in this country on health care. Now, amazingly enough, it's not because of the cost of the health care professionals, but whatever not directly, but every time we order a test that's not necessary, every time we order a drug that's more expensive than it should be, we're contributing to it. In the United States, we pay on average about $8,200 per capita every year on health care. These are the 2010, which are the latest ones that are published. I have the preliminary from 2014, and they're not much different. The figures are a little bit higher, the numbers, but nothing else. A couple of the positions here have changed, but not by much. The average for developing countries is about 3,300. Look how much higher we are. The next country down is Norway, where absolutely everything in health, everything you need for health care is paid for. Everything. And it only costs them about $5,400 a year. But you say, yeah, but we have the best health care in the world, right? Well, I don't know. If you look at this, you say, this is America as the outlier, health care spending. Look what's happened. This is our health care expenditures as a percentage of our gross national product. It's actually now close to 18%. And look at the other countries. Now, but we have the best health care, don't we? Oh yeah, look at this. Look at us, way over to the right. So our average lifespan is about 76 years, and we spend over $8,000 a year. The best is Japan. But of course, a lot of that is lifestyle too. But look at how many countries are better than us. Even South Korea is much better than we are. So something's wrong with our system. And a lot of it is because our professions have allowed business and legal people to take over our profession. And it's time to take it back. And what you people are doing in this room right now is part of the answer. I truly believe that. Because working together, we can make some of these changes and force them back to where they should be. Now, I really think if you read the life of Albert Einstein, it's quite interesting. One of his famous sayings is, and I don't like the business of man, but he says, try not to become a man or woman of success, but rather try to become a man or woman of value. And that should be what we're about. And Sir William Osler, who was probably one of the greatest physicians that ever lived, he said, the good physician or healthcare professional will treat the disease, but the great healthcare professional will treat the patient. Thank you. Any questions?
Well, that was fantastic. I can tell you my Jewish mother had a brag book that she was very happy to tell everybody about. So, yeah. So, first of all, we wanted to thank you very much. So we're hoping that you will accept this gift as a memoriam here, and also a token of our appreciation for your being here, as well as for all that you've done through your amazing career. So thank you for that.
My pleasure, and thank you all. So we're gonna
Yeah, so now we're going to have a local sort of response and discussion about all of the really provocative thoughts that Dr. DeAngelis has brought forward. And so it's a little awkward for me to ask the former dean of the College of Pharmacy to come after a discussion about Big Pharma. But, you know, it's always amazing. It's amazing to me. So this is Dr. Frank Ascioni, but it's also amazing to me how things always pop up when we are teaching. So Melissa Gross, who's going to be on the panel, is going to come up, was talking to me this morning about teaching about skull and skull structure, and how now there's a new hominid that's been discovered, and how she was going to use that in her course today to help her learners think about the actual anatomy of the previous hominid and our current hominid. I was thinking this morning, the Huffington Post has a whole article about risperidol and the difficulties with risperidol. So it's amazing how these things come up all the time. And so Dr. Ascioni is going to introduce the members of our panel, and we're going to have a local discussion and response to this talk today. So, Dr. Ascioni.
Yeah, I mean, I deal in drugs. What could I tell you? But would our panelists come up and sit in their assigned seats, please? The individuals, and again, their names and their backgrounds are listed in the program, and I hope you have that, so we won't take up our time introduce them. They represent all the 7 health science schools on campus in Ann Arbor. And what we're going to do is get them to share, since I thought Dr. DeAngelis made a wonderful approach to the broad concept of how this applies beyond medicine. And we're going to get our colleagues to really start to give the perspective, to broaden this out. And professionalism, as we've all agreed, is an area that touches every profession, every caregiver. So the first question, and this applies to all of the individuals, and I'm going to ask them to kind of go down order, is how does your school or your profession deal with the professionalism issues raised by Dr. DeAngelis? Caroline, you want to start? No, it's not.
Can you hear me? Yes.
I just walk over there.
So, thoroughly enjoyed your presentation, and it's a very timely question. On the profession side, this is something that's been a great concern to all of us, the changes that are occurring in the practice of dentistry, and business influences and legal influences, certainly. And this year, the American College of Dentists, which is an organization whose goal is to promote ethics and professionalism in dentistry, is working with the American Dental Association to conduct a comprehensive study of the profession of dentistry as a profession and its role in society, with recommendations for change to help preserve our role as professionals and also go back to the basics, to go back to what we all went into this profession for, which is to serve the public. At the school side, as part of our educational programs, ethics and professionalism play a major role in our curriculum. We have a 4-year program in ethics and professionalism, and I think where the students really learn it is in the field in our community-based dental education program, where they're working with underserved populations and are asked to reflect upon what they've learned and what that experience means to them. So.
Melissa?
Thank you. It was wonderful. So in the School of Kinesiology, we have a lot of undergrads who are aspiring to get into professional graduate schools. So not so much of our programs are specifically targeted towards the professional skills and attributes that you mentioned. But we do have a couple of instances of that in our Department of Movement Science. We have an intraoperative neuromonitoring program that has just started up. It's actually the first one in the country for an academic program that prepares students for that certification. And so the undergraduates are actually in the OR. And so they're learning by observation and working with professionals in the OR as part of the team. I actually heard an undergraduate come up to me excitedly and say, "Oh, I was so glad that I learned this particular muscle in musculoskeletal anatomy because an orthopedic surgeon asked me where it was." No, I'm sorry, it was a neurosurgeon. The orthopedists know it. The neurosurgeon needed a little help with the musculature of the arm, I guess. I didn't want to get too close to that one. But I think that their eyes are opening and very excited to see this kind of interaction and practice. In general, I would say that students in the School of Kinesiology, the undergrads who are looking to become physical therapists, dentists, physicians, occupational therapists, PTs in the future, they have the benefit of being at Michigan, where we value diversity, and we value that on the ground in that in many courses we're looking to see how to be as inclusive as possible in building those communities, so that the word trust, of course, is going to come from respect of people of professional diversity, disciplinary diversity, as well as all the other kinds. So we're tackling that as a faculty to try to prepare the students to be open-minded when they get to a professional piece.
Raj?
Sure. Thank you, Dr. DeAngelis. That was great and very, very illuminating, and certainly central to a lot of the concerns that I think many of our different professions share. We do spend, I think, a lot of time talking about unprofessionalism when we talk about the concept of professionalism. I think there's two sides to that we must tackle together. One is to really highlight where there is unprofessionalism and potentially even put in structural changes to minimize what our students see and what our students participate in, because that is a real shaping and powerful influence on them. But then I think it's also about rewarding and highlighting some of the positive role models that we see where people are managing conflicts appropriately, where we're really wrestling and dialoguing with some of the tricky cases that come before all of us as it relates to the different interests that we may carry with us. I'm actually really, I'm very excited that we're at U of M, and really the whole health system really jumped into this a number of years ago, led by our senior leaders, Dean Woolscroft and others, to really recognize that the things we were seeing as it related to industry relationships required a structural change. And so before, I think most of the health systems across the country, we removed the ability for sponsorship of CME activities from industry. We prevented their presence on campus, or very closely restricted what their presence on campus would be. And this is now almost 8 or 10 years old, I think, at this point. And it got a lot of press in the New York Times because it was very, very different. And it was driven by a lot of the data that was published in your journal, things that Susan Gould has published around on ethics and decision-making and conflict of interest. That, I think, really started to change the culture around the health system as it related to not that industry sponsorship is necessarily a negative influence, but that we must manage that conflict in a much more structured way. In the medical school, every lecturer or every faculty member that interacts with the student must declare their interest in their talks, in their lectures, as part of the educational curriculum. So it's kind of part of the explicitly thinking about this on a regular basis, which I think has really, it's really served our institution well to create that culture. The culture we're really striving for, I think, is the one that you put on your slide, primum non nocere, which is above all, be not silent, which is kind of the Socratic approach to medicine that I think we're all part of. And I think, how do you build that culture in a hierarchical, dominated profession when speaking up can be very tricky? I think is probably our greatest challenge. And when you said that all of us coming together is probably a great step towards the culture we want as it relates to professionalism, I think this really is a step that we must take, because if we diffuse the hierarchy among our professions, between our professions, and then within our professions, that's something I think we must strive towards with very specific interventions. So I think there's two sides of it that we struggle with, and we don't have the answers, but I think if we move towards better dialogue and culture, we'll start to see what the positive role models are in professionalism that we strive for.
Michelle.
Thank you. As nursing, we have been the most trusted profession forever, except for in 2011 when I believe it was the firefighters or police were actually the most trusted profession. So there is great responsibility at the School of Nursing as we are educating those students to go out and participate in the profession to maintain that level of trust that Catherine had talked about also. We have pretty explicit lessons and lectures and our didactic information, not only for the undergraduate students, but even for our graduate students. We talk about professional issues, we talk about conflict of interest. We try and have those conversations in class with the students. What are you seeing in clinical practice? So we have the opportunity to do that in the classroom, but we also rely heavily on what happens out in the clinical world as they are working with their preceptors. And so we really do try to ensure that the preceptors are at the highest professional level also, so that we can get the attributes for our students to be out there and practicing in the world. Nursing as a profession has always been very, very strict with itself, and so the self-monitoring of unprofessional behavior, breaches of licensing and all that kind of stuff is pretty well maintained within our practice, which contributes to, I think, us being the most trusted professions. But I do believe that all of the activities that we have going on, all the interprofessional activities that we have going on, has been also another great way to indoctrinate students into how to interact professionally with each other, and that will translate again into how we interact professionally with students and the rest of the healthcare system.
Bruce.
In the College of Pharmacy, we deal with some of these pharma issues that we saw on these slides. We have an evidence-based medicine thread where we talk about what is the evidence, how do you use the evidence, and at the end, how do you make new evidence that makes a difference in patients' lives, and what does it mean when something's in the internet? Does that mean it's true? No, not necessarily. And how to apply that evidence to the patient. Remember that the patient's the most important thing. To follow up on what Michelle said, one of the cool things at this campus right now is the start of this interprofessional education that we've been working on and putting together this clinical decision-making course where we're bringing together social work and dentistry and pharmacy and medicine and dental, it's 5, I believe, all in the same team. And students learning to be what not only is it like to be a pharmacist, but what is it like being a pharmacist and representing that profession in a team? And there's times when you have to lead that team because it's a drug-related thing. And then there's time for you to be quiet and listen to what the social worker's saying, because what's going on is a social work issue. We need to learn from each other in such a way. And sometimes the professionalism is leading, and sometimes it's being quiet and coming together as a team to come up with the best decision. I think that particular class is our first step that we've done all together. It's taken a big effort to do, but to teach how we can all be professionals in our own profession, but coming together we're something more. And that's a neat thing that we're doing in that class.
Matt.
I'm going to echo a couple of the things that have been said already. At the School of Public Health, essentially, professionalism is taught through principles and pragmatics. Principles are coming through from the professors as they lead their courses, no matter whether it's epidemiology or biostatistics, which might involve how do you measure community health issues or individual health issues in a responsible, professional way that doesn't impinge on the freedoms and privacy of individuals, or other opportunities, for example, trying to help individuals and communities change their behavior. There are critical principles about humanity and equity and community that are also part of the approaches that are taught at the school. Then we have the pragmatics, which are about the opportunities for individuals at the School of Public Health to learn about the practice and the professionalism of public health in community placements, whether they be direct public health service or opportunities to do research in a responsible way. When I talk to students at the School of Public Health about their sense of professionalism, it's a sense of being a community taking care of communities. And that to me is a beautiful way to think about the responsibility that a profession has to the communities that we're trying to serve.
Mary, or last but not least.
Okay, I'm going to talk a little bit about the school social work as part of this team. I think our professional school has been really focused on, I think, very similar points that were raised already, but the primacy of the patient, or the patient-centered and family-centered care. And I think one of the things that we try really hard to do within the school of social work is to actually add this like lens looking at the world through this like just practice or the social justice approach to understanding the context and the lives of the people who we are serving, and also understanding and getting meaning from the patient and their families about what makes a difference. So a lot of our educational process and a lot of the work that the students are doing is really looking at that person and environment configuration. And we really emphasize with our students not just knowing how to do the face one-to-one or family type work, but understanding the policies and the access to care and the pathways to care and what that means for how we oftentimes look at the outcomes that can occur for different populations that we work with, and trying to make change happen. Because I think if we don't give voice to some of those, oftentimes it's the silent part of the healthcare field. So we really try to encourage our students to be advocates within the settings, and also to have the skill set they need to make a difference in the one-to-one work that they may do or the organizational work that happens. Ours is very much like all the other applied fields here. We have our students doing field placements where we do rely quite heavily on the supervisor or their mentor, or the licensed professional who instills with them some of the skills that they've learned. So we also have a big emphasis within our school around continuing education of our alums and our professionals out there that the field keeps changing, and how do we help our field stay current and help new practices to come into play. What we do know, and I think a lot of the research shows, it's always easier to start with somebody new than to go to somebody who's already been in the field and ask them to do something different. So it's, I think, a combination of those factors that we also have to think about. But I just really enjoyed this talk, and I think the whole focus on trust is central to all of our schools.
Okay, I'm going to open up to anybody on the panel for the second question. Now, you've all listened to each other in terms of describing or interpreting what Dr. DeAngelis said. When you listened, or what you're aware of, what do you think the commonalities is in interprofessional education? As we all know, we want to draw together and look at common. And what are the commonalities and what are the differences that you've heard as we've approached this area of professionalism? This is open to anybody on the panel. So who wants to volunteer to go first?
I'm just going to say primacy of the patient, and I think I hear that across all the professions.
Other thoughts?
I think I would agree completely. The primacy of the patient, the social contract. I think there's something unique about being at a public university like the University of Michigan, where we actually we have to think about the publicness of being here, the fact that we do have a very direct responsibility to the citizens of the state, and what that means for the primacy of the patient. Are we really responding in our educational programs to what our patients really require? Our patients require and desire that we work together in teams in ways that are highly functional, highly effective. And I think the questions we're all asking in our 7 schools are we creating the programs that really support that? So I guess I'd build on the primacy of the patient to say the primacy of society is our ultimate service.
Others? It's commonalities and differences, if you pick some up. Go on, Matt.
One of the themes in your talk, Kathy, was about this external threat to professionalism. And I think that one of the great challenges that we have is identifying those threats and then strategizing common responses and also responses that may differ by profession. So we sort of chuckled a little bit uncomfortably about the fact that there were 2 representatives of the School of Pharmacy here, and how was that connected exactly to the behavior of the pharmaceutical industry? Answer, not very much. But the opportunity here is to actually respond as one unit coming together around a common set of threats. There are other types of threats. For example, the threat of loan repayment burden on our health profession students is a critical question. There are also threats around the need to serve our rural areas better in all of our states with all of our professions. And how do we do that in a functional way that serves the needs of the patients? We may decide that some rural areas need a different balance of pharmacists and nurses and advanced practice nurses and physicians and social workers than our urban areas do. Is that okay? How do we come up with that best balance? These are all external threats that are going to require some coordinated responses across our professions.
Any other comments, any differences that you noted? You can make a comment anytime you want. I was going to ask you at the end, but what the heck, you're in charge. Go
Well,
on.
no, this is pertaining to this, because one thing we all agreed on is the patient's the center. Without the patient, why do we exist? And yet, and this is something I mentioned to Raj last night, in your courses that you teach together, why don't you have a patient? Do you use actual patients in teaching clinical skills? Do you use them? Well, why not take 1 or 2 of those people and include that person as a faculty member? I'll tell you, one of the things in writing the book on patient care and professionalism, or editing it, one of the chapters I learned the most from was the one written by the person who wrote the chapter and teaches at the University of Wisconsin. She teaches a course on patient advocacy. She's a 19-year survivor of ovarian cancer, which I say God keeps her here to do just that one thing. And I learned so much from her, and I'm just a suggestion that you might consider.
Anybody want to react to that?
Well, I actually would love to hear you talk a little bit, Dr. DeAngelis, about what do you think patients think about the differences among our professions? Because I don't think they want us to be playing the same role. They obviously don't. They want us to capitalize on our unique expertise. But how do they want us to be working together and thinking about the commonalities, but also distinguishing ourselves so that we play a functional role?
Well, as someone who's been a patient more times than I'd hate to admit, I can tell you that if you ask a patient who they think, now it depends. If you ask a hospitalized patient, who is the most important person? Now, don't talk about knowledge or anything. Who is the most important person to you? And who got you through this? Who do you think they'd say? The nurse. Absolutely. And believe me, that would be my answer. But when you say to them, who do you think pulled you through this, made a diagnosis, and got you? It would be the physician. And then if it's a traumatic kind of thing, hit by a bus, you ask me who helped me the most? Physical therapist. No question. Made a big change in my life. If you ask people who aren't as well off as we are, you ask them who helped get you through this illness or your family? The social worker. Now, people who have problems with their teeth, they'd answer the dentist, of course. So you're absolutely correct. They need us all. But the thing is, we all have to understand each other, and we have to understand what's important to us. And if we argue about who's the leader of the team, we're going to get nowhere. And I want to reiterate what I said before. It depends on the circumstance. I'm going to just tell you one thing that happened to me. I was a nurse before I went to medical school. I never wanted to be a nurse, I should tell you that. I knew I wanted to be a doctor when I was 4, okay? But I was told, my parents were told, that girls who wanted to be doctors had to be nurses first. I'm not that old. I'm only a 57-year-old dyslexic person, but I mean, it was way back then, okay? So, but the thing was, I was on a rotation, and it was in a male medical ward. This is way back in the 60s. And I was on rounds, and I heard some commotion down the end of the ward, and it was a gentleman whom I had taken care of. He was someone who was in and out of hepatic encephalopathy. And he kept saying, I don't want to go until I thank my nurse. And the head nurse was there, and she said, but this is your nurse. He said, no, my nurse. And she said, but this is your nurse. And I heard it. And I looked at him, and I thought, well, I want to say goodbye to him. So I came down, and I said, Mr. Jones. He said, there's my nurse. And the head nurse said, she is not a nurse. She's a student doctor. And he looked at her in all seriousness. He said, look, she talked to me like a nurse. She touched me like a nurse. She is my nurse. And I'm going to tell you something. My classmates asked me to teach them, and I used to teach a course at night. How do you approach and touch a patient? And I learned it in nursing. I sure didn't learn it in medicine. So we need each other, and we can learn from each other.
Okay, I think we answered that question. Wait, who knows what the question was? But the last question we're going to ask, and then open up the dialogue if we have time, and you all touched on it to some extent, because the end of this is how do we specifically educate our students? And what leads into that, as you all know, because you've talked about, is how do we get together to do that? But this is an open-ended question, so anybody can offer their perspective on, the values we talk about. How do we actually apply those? I know some of you are addressed in your comments, but reiterate and maybe focus a bit. So anybody can comment.
I'll kick things off. Some of you may know that I recently had the opportunity to serve the state in the Department of Public Health as the Chief Medical Executive, and one of my roles was to lead the state's response and preparedness to Ebola and the challenge of Ebola. That was the very best experience I had in our state in terms of interprofessional response to a health threat. It was led by several graduates of our School of Public Health who work in the Department of Health and Human Services for the state. But one of the key components to it that I saw at the learner level, the trainee level, was here on campus, and it was led at the School of Art and Design, actually. And it was called a charrette around Ebola. And the idea was for design and engineering and, yes, some health profession students to get together and try to design ways to respond to Ebola in West Africa, not here in the U.S., because fortunately, as you know, we've had very few cases here. One of the most remarkable inventions that students came up with over the period of just a few days was a covering that you would put on essentially as a big drape with sleeves that would allow you to hug someone who has Ebola. Okay? That is awesome, because that is about the patient, that is about humanity, that is about principles and practice in action, and that came from students, not from fully trained healthcare professionals who've been out there for their whole careers, but from the ingenuity of our students. That's the sort of opportunity that's very real and real time, responding to external challenges and inviting our students to be part of the solution in a very concrete way. That's what excites me here on this campus about interprofessional education.
Caroline, you were going to add something.
I think the first step is to put our students together so they get to know each other and understand each other's roles and responsibilities, so that over time they'll be comfortable having those collaboration and communication with each other. And I think the work today also demonstrates that we have so much more in common about how we educate our health profession students, that as faculty we can learn from each other and do more of that education together, which is, again, all kind of tied up into the old theme of interprofessional education. So you just have to start somewhere, and putting the patient in the center will help make it all relevant and also prepare our students for whatever practice will hold for them. It's not going to be the same as it is today. And that's something we tell our dental students, is that the way dentistry is practiced today, dentists are not typically in the hospital setting. At least there are dentists there, but they're not as often within the team-based environment. But that is changing, and we have to prepare them for a future we don't really know what it's going to look like. So the first step is to put them together, and the students from Michigan will actually shape the future. And that's, I think, our main goal for what we're doing with IPE here on campus.
Mary,
I think the other thing that goes along with getting our students together is actually looking at our faculty getting more together, not just around research projects, but around the teaching and the education, and learning the different ways that we can improve our instructional technologies and our instruction crossing systems, thinking very creatively and out of the box, because maybe all our students can't meet at the exact same time, but they can learn together. And so I think faculty, it's the same thing, is how do we make that time to learn from each other about the ways that we need to model this for our students too.
I was going to build on what Bruce had mentioned earlier about this clinical decision-making course. It's really a phenomenal model for a lot of the principles that have been talked about. And so there's a real specific example. I don't know where the poster is, but if you guys have a chance, go and see that poster or talk to the people involved. It really was a remarkable experiment that's going to continue. Basically, the 5 schools set up modules across the 5 different school buildings where the students from the different schools would come together and work on cases that were a little bit more relevant to that school, but then they would rotate like a Ferris wheel, 2 weeks in each of the 5 different schools. And the two things, I got a chance to audit, just kind of sit in on a couple of sessions. And the two things I observed, which were fascinating, first of all, having medical students with dental students and all the other students around the table prompted, they would spend about half their time discussing the case, and then half their time they would ask each other these really interesting questions like, how old are you? Because we are all coming from various different levels, and we actually have very little awareness of what training is like in everyone else's group. And they would say, you're 23, but you've been in the clinical setting for 3 years already? That was sort of the light bulb that I saw happen over and over again with medical students. The second thing that I saw, which was, I think, genius on the part of the course designers, is that they brought 2 faculty to teach at each of the 5 different sites. And one had to be from that school, and one had to be not from that school. So it was, to Mary's point, bringing faculty together to actually construct the module and to facilitate the discussions in ways that we never get a chance to do in our standard siloed-based lives. I think it's a great experiment to build on, and if we can create more of those opportunities, I think we're going to start to see the kind of momentum we need to around this movement.
Yeah, that was the instructors that were in that class. A lot of them are in the audience. Would you raise your hand? 2 there, one over there, one over there. I don't know if Gundy, there she is. Okay. There's an extraordinary group of people that put that together, and they did it on their own. The dean sort of just supervised and nodded their head, so it's nice the public acknowledge what they did.
What's neat about it is I lead one of those sections, and there's professions in there that I don't know very much about. Dentistry, for example. I'm not a dentist, and nor is my partner, who's a physician. We don't know anything about it. It's okay to be dumb, which is a very hard thing for a faculty member to learn, that you don't have to be the smartest one in the room. And when our case would snake around to a dental question, I would say, I don't know what this is. Dental students, teach everybody else in your group about this issue. You have 2 minutes. And then the physician and I, who are the faculty, we just shut up. And then the room comes alive because everybody gets a chance to be the expert, which is really what happens on our teams when you think about it. And to allow the students to teach the other professions, they are so proud to do it. They're so excited to be able to talk about this because at any given time, sometime in that 2-hour period, somebody's the expert and somebody else is the student. And it rotates. And it's organic because I never really know where it's going to go. Even though we teach the same module over and over, I never know where these students are going to go. And it's okay to let it loose, let the reins loose, and let them teach each other. It is the coolest part about the course.
Any other comments? Dr. DeAngelis, would you like to react to what you've heard here? Any other comments you want to add to?
I just want to say what you have here is magical. Don't give it up. And make sure you share this. I love some of these papers that I hear. Make sure you publish them. I sound like an editor now, don't I? But I'm serious, because if you don't publish, you don't share, and other people won't know it. The only other school I know of right now who has something even close to what you're doing is Oregon. They built a brand new building that is just for all of them. But you are further ahead, even though they started before you. So you might want to contact them and exchange notes. You might learn from each other, God forbid.
Well, I want to thank my panel colleagues. I want to thank them for being brief. That was very good of you on their comments. Would you please give them a hand for what they're doing?